So, good evening, everyone, and welcome back. It's actually overwhelming that this is the third part of a discussion on only the fetal phase. And we've kind of taken this discussion over 3 months, and we still have an overwhelming number of mm, delegates joining in. So, thank you very much for coming back. If you all remember, we started 2 months back when we did the first session on just the normal imaging of the fetal face. What are the expected planes? And then Dr. Lakshmi Ravi took us through some very nice renderings of the face palette and how to detect the anomalies. Then the next session we had last time was on how to work up whenever a facial anomaly is detected. And the session went on so long that we decided to break it into two. And last time we conducted one half of this, and now Dr. Shagun is going to take it forward by working up further once the anomalies are seen, how exactly what genetic test to plan, what are the other things to look for. So we are looking forward to a very, very enriching session today also. And we are very thankful to Dr. Bimal Sahani to be present here as one of our senior mentors. And the presence of the president of SFM is always an encouraging thing. And sir, we will look forward to your inputs at every stage of this program. With that, I'll hand it over to Dr. Shagun to start with the case presentations.
Uh, Thank you, Dr. Chinmay. So I think Dr. Rupa, you can please introduce our new panelists today.
Yes, ma'am. First of all, good evening all. Today we have a new faculty, senior faculty, Dr. Kaushik Mandal sir. He is the additional professor at Department of Medical Genetics, SGPGI Lucknow. He has numerous ongoing researches and around 70 publications in index journals. I welcome you, sir. And now I call upon Dr. Chinmay madam to deliver her welcome address.
I think
I've already welcomed everyone, and this being a very close-knit SFM family, I mean, really, we feel very glad meeting each other again and again. I hope to see all of you physically in the CardioCon and again in the FetoCon, as we have really exciting programs happening on site this year. So right now, welcome to this particular edition of the fetal face discussion. And Shagun, madam, you can take over.
yes. So let's now move on. So last time we have discussed, as Dr. Chinmay has mentioned, about the upper face. So we have discussed when we have a abnormality in the upper face. So how do we go about the workup? So we'll just do a very brief recap of that. Just move the slides, Dr. Rupa. Next slide. So what we saw last time were basically three anomalies. We first looked at holoprosencephaly. So we know that this is basically a severe brain malformation, usually has a poor outcome. And then we also saw how this can be caused by chromosomal disorders or microdeletion, microduplications, or single gene defects. So then we also then subsequently kind of inferred that whenever we see holoprosencephaly, we need to do a microarray ideally. And also, in addition, we also should be thinking about doing an exome sequencing to look for the single gene etiologies. Because often most of these patients, we know they are going to terminate their pregnancies, but then there would be the single gene types which would actually have a very high recurrence risk. So it's very important to make a genetic diagnosis irrespective of what the couple decide. And one more important thing, because this was a webinar on face, so another thing what we discussed was that sometimes the face can have some very minor subtle findings, which if you see, then you should take a closer look at the brain and you should start thinking that could this be some kind of a milder form of holoprosencephaly. So the next thing we discussed was the binder faces, which is basically more of a dysmorphic face rather than a malformation per se. And we also saw through one case how sometimes this can be just a normal variant, a benign finding in some families. And but then on the other hand, it could be part of Down syndrome, it could be part of a skeletal dysplasia. Sometimes it could be caused by certain teratogenic effects like mother taking warfarin, mother with SLE. So whenever you see this finding on scan, we need to think about all these things. So we should surely do a karyotype and if possible a microarray also. And then if this is normal, then we should also do exome sequencing for the skeletal dysplasias. So we really need to rule out both these categories of genetic conditions. And then if everything is normal, and if you can see that, if you look at the parents and you see that they have a similar kind of face, probably for that family it's a benign variant and you can reassure them. Next, and then we had a kind of an animated discussion on the hypoplastic or aplastic nasal bone, and what we finally kind of concluded was that if we see it in the first trimester, if it has additional findings, we should investigate then and there. If it is isolated, then you reassess in second trimester. Here again, if it persists, then one important thing we need to know that this is primarily a marker for Down syndrome. That is the thing which the condition for which there is a highest risk once you see this. But then we also saw that there is, Dr. Gayatri presented some cases where there were some microdeletion microduplications in the baby detected by microarray, which had presented with this finding. So the test of choice, ideally in such situation, if we look at some of the recent papers, is that we should be doing invasive testing and doing a microarray. But of course, still we don't really have guidelines, clear-cut guidelines. Even ACOG guideline does not clearly say whether we should do invasive or settle with NIPT. So last time Khurana sir had said that we should be probably coming up with the Indian guidelines, and SFM is working towards this. So now today then we are going to talk about the findings in the lower phase. So then I'll give it over now to Dr. Neelam, and she is going to show us the first few cases, and then we'll discuss. Dr. Neelam?
Yes, ma'am. Thank you, ma'am. Good evening, Kaushik sir, Vimal sir, and Chinmay ma'am. And so now we will start with lower face. In that first, we will discuss about orofacial cleft. So cleft is interruption of the lip or the alveolar ridge and the palate. It can be unilateral, bilateral, and median. The defect may involve only the upper lip, then it will be cleft lip, or extending into the hard palate, then it will be cleft lip plus palate, or involving only the palate, then it will be cleft palate only. Prevalence for orofacial cleft is around 15 per 10,000 birth. Etiology could be multifactorial, can be environmental, or can be genetic in etiology. So coming to the classification of orofacial cleft, so they can be unilateral, bilateral, median, and sometimes can be atypical cleft lip or palate can be there. So here we can see the first thing, integrity of lip and palate is maintained. This is normal. So here we can see this one is isolated cleft lip. Here we can see unilateral cleft lip and involvement of palate is also there. So this is cleft lip plus palate, unilateral. In the down, the first one is bilateral cleft lip plus palate. Here it is isolated cleft palate, and here it is bilateral cleft lip and palate. So cleft lip and palate they are telling, many literature, according to many literature, they like cleft lip plus palate contribute around 50% of the cases, isolated cleft lip in 25% of cases, and isolated cleft palate in 25% of cases. And at least 30% is syndromic etiology, and non-syndromic are around 70%. And that is important to know because non-syndromic can be repaired and the prognosis will be very good and outcome will be good, and then counseling can be done accordingly. Cleft palate can also be complete or incomplete. And then next is median cleft lip. Median cleft lip reflects a deficiency of the central portion of the lip, including the central vermilion, the philtrum and premaxilla, and the nasal columella. So there are many syndromic associations with median cleft lip. The most important and the common association is holoprosencephaly. Then lateral cleft, facial cleft. These are atypical facial cleft, often begins at the corner of the mouth and extend outward, with the most severe forms reaching up to the ear. They may develop as error of early embryogenesis, although they may also be due to the disruptive effect of amniotic band syndrome and occur later in the development. They can be associated with skeletal malformation of the lateral face and external ear. So there are many syndromic associations are there with the orofacial cleft. The chromosomal disorders, they're most commonly associated with trisomy 13 and 18. In microdeletion syndrome, they are commonly associated with digeroid syndrome, that is 22q11.2 deletion syndrome. And in single gene disorders, the most common are Treacher-Collins syndrome and Stickler syndrome. And many other syndromes are also associated with orofacial cleft. So coming to the case discussions, this is first family. Here the couple is third degree consanguineously married, and this was the third pregnancy. From the first pregnancy, they had healthy girl child. From the second pregnancy, the healthy boy, and from the third pregnancy, they referred to us with abnormal ultrasound findings at 20 weeks of gestation. So detailed scan was done, and we found that there was unilateral cleft lip. Here we can see the cleft lip, and here cleft lip plus palate was also involved. In the face, there was flat face with flattening of nose, and hypertelorism was there. Then fetus also had CNS findings. Here we can appreciate the ventriculomegaly was there. There was dilated third ventricle. There was abnormality in the posterior fossa cyst and abnormal vermis, and that was like Dandy-Walker malformation. And here also we can see the vermis was hypoplastic. So with these findings, family was counseled and they decided to terminate the pregnancy. And after the termination, baby was brought for fetal autopsy. In fetal autopsy, all the scans see the baby is having left side cleft lip plus palate, flat nasal bridge, and significant hypertelorism. In brain findings, there was severe ventriculomegaly, and here we can see hypoplastic vermis. Brain histology was done, and that was suggestive of lissencephaly. So with the findings of CNS finding, consanguinity, and all these findings, we decided to go with further genetic testing. The amniotic fluid karyotype was also done, that was normal, and whole exome sequencing was done, and we found that homozygous pathogenic variant in FKTN gene, and that the FKTN gene pathogenic and likely pathogenic variants are associated with congenital muscular dystrophy, dystroglycanopathy with brain and eye anomalies type A4. This is also called as Walker-Warburg syndrome. And after that, family counseling was done as per the final diagnosis, because this is autosomal recessive disorder, and there is 25% chance in the every pregnancy the baby to be having biallelic pathogenic variant. So poor prognosis in view of multiple malformations, severe CNS involvement was explained. Histopathology and parental consanguinity help in deciding and to proceed for whole exome sequencing. Recurrence risk prediction and early prenatal diagnosis can be offered, and option of pre-implantation genetic testing for monogenic disorder is also possible after the accurate molecular diagnosis. Coming to the second family, this couple is second degree consanguineously married. They referred to us in fourth pregnancy, and before that, 3 pregnancies were terminated in view of only cleft lip. In the fourth pregnancy, also ultrasound scan findings were of cleft lip and palate only, and the detailed scan was done. And here we can see the bilateral cleft lip and palate, flattening of facial profile and retrognathia, and hypertelorism. No other major malformations were detected on scan. A family was counseled, but still they decided to go for termination. And the fetus was brought for fetal autopsy, and in fetal autopsy finding also, we can appreciate the findings of bilateral cleft lip and palate and significant hypertelorism. The extra finding was only digital dysmorphism in the form of broad hallucis. Here we can see the broad first grade toe bilaterally. And because there was recurrence and there was second degree consanguinity, we strongly suspected some genetic disorder. So whole exome sequencing was done, and pathogenic variants were detected in TMCO1 gene. And these variants in this gene are associated with autosomal recessive craniofacial dysmorphism, skeletal anomalies, and mental retardation syndrome. And this is a very rare syndrome, and only less than 20 cases are described in literature, and all are described as a pediatric cases. No prenatal cases are reported in literature till date. So whole exome sequencing will be decided in view of recurrence and consanguinity. And here in this case, apparently isolated cleft lip and palate finally turned out to be autosomal recessive syndrome with mental retardation, and it is a severe neurodevelopmental disorder. So now Sagun ma'am will discuss further.
So basically through these 2 cases, so what we have seen are both single gene disorders. So, but again, we need to be aware that before going for single gene testing and high-end tests like whole exome, first we have to, of course, rule out the chromosomal abnormalities. And even before that, first the detailed scan is very important, because 70% of cases of orofacial cleft are isolated with a very good prognosis, with good postnatal surgical outcomes. So it's very important that we know this and we counsel the families about this. But then those 30% ones which are syndromic, for picking up those, we need to really, one thing, first step, of course, do a detailed scan and then look for associated abnormalities. So again, there are some empirical figures available. So if you have only cleft lip or cleft lip with palate, whether it's unilateral or bilateral, that kind of decides that what is the possibility of associated anomalies. So it ranges from 15 to 30%. If you have basically a cleft lip or cleft lip with palate. So again, if it's bilateral, if palate is involved, the percentage is higher. If you have only cleft palate, then 25 to 50% would have associated anomalies. If you have a median cleft lip, then this is even more than 90%. So majority of these actually will be having holoprosencephaly and or some other genetic conditions. So it's a very high percentage. So here you should be really careful and look in the scan much more carefully, especially at the brain. So once as per the scan findings, you can say if it's isolated or syndromic, then further we need to do the genetic workup. We should again involve looking for chromosomal abnormalities, looking for copy number defects, which is basically microdeletion, microduplication, and looking for single gene disorders also, as we saw in the last two cases. So again, with isolated cases on scan, the percentage or the yield of genetic test is much lower. It's around somewhere on an average, you can say 5 to 10%. Whereas if there are associated findings, this yield will be really high. So if you add everything, you can say around more than 50% would be the yield of a genetic test. So seeing the scan properly and then doing a comprehensive genetic testing, focusing on all the different categories of genetic disorders is important. So you would basically be doing a microarray and also doing an exome. Again, sometimes this can be guided because there are always time constraints, cost constraints. So depending on the family history, like here in these cases, we had consanguinity, we had in the second case recurrence. So we automatically start thinking that this is probably autosomal recessive condition. Then we need not do a microarray. So taking a history becomes very important with respect to the family. So there are more than 400 syndromes which can present with a orofacial cleft. It's not possible, of course, for anybody to remember the whole list. And next slide. So what we need to basically know that we should be trying to do a genome-wide kind of genetic test. But before doing that test, it's very important as imaging specialist for you to do a detailed and careful scan, look for associated abnormality, then also ask a family history, ideally make a 3-generation pedigree. Also, if possible, examine the parents or the siblings. Sometimes they may have some minor clefts. Sometimes some conditions they have some lip pits and all, certain genetic conditions. So you can look at them. That may give you a clue that this may be something genetic underlying. And then of course you should think of single gene disorders more if there are recurrence, if there is consanguinity, and investigation should ideally involve microarray, which will pick up all your chromosomal abnormality, microdeletion, microduplication, and exome sequencing, which will pick up the single gene disorders. And after all this, if everything is normal, then actually you can say this is truly isolated. And then you can reassure the family so that they can continue the pregnancy. You can then refer them to, of course, the plastic surgeon, and who can counsel them about the postnatal outcome. So another aspect, of course, of genetic testing is that we can also provide recurrence risk counseling. So like in the first case, so we already in such cases, we know the prognosis is poor. Family is going to terminate the pregnancy. But still, if we make a genetic diagnosis, we know what is the recurrence risk for next pregnancies. We can offer them early prenatal testing by CVS or offer them even pre-implantation genetic testing. So doing a genetic workup is always important. So I think we can now go on to the second case, which will be by Dr. Gayatri. You can
Good
stop
evening, ma'am.
screen sharing, Dr.
Yeah.
Neelam.
Yeah, good evening, one and all. I'm thankful for SFM again for giving me the opportunity. Now the case is regarding the fetal micrognathia. So we all know that fetal facial abnormalities could be either because of teratogen exposure or some intrauterine factors which may lead to the abnormality in the fetus, or sometimes multifactorial etiology, and sometimes it could be a component of genetic syndrome. So the presence of facial fetal abnormality does not always mean a genetic syndrome. It is important to identify the exact etiology among all these etiologies because there is varied prognosis and recurrence risk when we do the detailed workup. So what is the need of doing a detailed workup is when we identify a genetic etiology, it has an important implications for the pregnancy management. If it is due to the other reasons, then the recurrence risk and the implications in the pregnancy will differ. So this is a case where the couple are non-consanguineous, and in the first pregnancy, they came at NT at 60 in the NT scan. It was normal, and at 16 weeks, we have found that there was micrognathia and postaxial polydactyly. That first trimester screen was also low risk for trisomy 21, 18, 13, but at 16 weeks there was micrognathia and postaxial polydactyly. And this is a lateral profile of the fetus. We can see that there is a micrognathia and there is postaxial polydactyly towards the little finger. So postnatally, actually they were counseled to for fetal autopsy also, but they are not willing, but they were advised to at least send the photo of the fetus post delivery, and they have sent the fetus. We can see that there is a micrognathia and there is postaxial polydactyly. This hand we could not see, but there is no postaxial polydactyly in the feet. So the workup was done. They were counseled, and amniocentesis chromosomal microarray was done. Chromosomal microarray revealed trisomy 13. Since the microarray has revealed trisomy 13, the case ended up with this particular testing. But if the same thing has been normal, then we would have gone to the exome sequencing. And in this case of trisomy 13, prognosis is guarded. We all know that since the prognosis is guarded, the couple terminated pregnancy, and they were told that the recurrence risk in subsequent pregnancies is 1%, and prenatal testing is possible if the couple decides. So trisomy 13, the incidence is 1 in 5,000 total live births. And these fetuses can present in any of these anomalies. Some of them can manifest with CNS anomalies. The most common is alobar holoprosencephaly, and they can present with microcephaly, anophthalmia, microophthalmia, cleft lip palate, and micrognathia, which are the facial findings seen in trisomy 13. And in the extremities, postaxial polydactyly is a common finding, or sometimes they can have CTEV and rocker bottom feet in the lower limbs. And most of them will present with genitourinary and GAT anomalies, almost in more than 50% of the cases. And some of them can present with severe fetal growth restriction. So if you look into the micrognathia, fetal micrognathia is always an ominous finding. The incidence is 1 in 1,500 live births, which is very common. And we know that chromosomal abnormalities account for almost 50 to 60% of cases of micrognathia. Out of these chromosomal abnormalities, trisomy 18 and triploidy are found in almost 30 to 40% of the cases. Out of 50 to 60%, 30 to 40% accounted by the trisomy 18 and triploidy. So when we look into the other chromosomal abnormalities other than aneuploidies, the copy number variations like 4p deletion, 5p deletion, 22q deletion, Cat syndrome, and monosomy X can also present with micrognathia in the prenatal period. When we look into the monogenic disorders, more than 300 monogenic syndromes are associated with micrognathia, and there is a big list of which, out of which we can say that syndromic monogenic disorders, some connective tissue disorders, some skeletal dysplasias, and some of the neuromuscular disorders, a broad category can be done based on the classification. And when we find an additional finding other than the micrognathia, it gives clue to these monogenic disorders or chromosomal disorders. For suppose if the micrognathia is isolated without any other finding, the reasons could be either it is familial, look at the parents or other family members to see whether there is micrognathia in some of the family members, or it could be functional. Sometimes there could be some temporomandibular ankylosis which may lead to micrognathia, and peri-Robin sequence is also one of the possibilities in cases with isolated micrognathia. So if you look into the monogenic disorders, which are associated with post-axial polydactyly and micrognathia. Since we have identified trisomy 13, we did not go ahead with the exome sequencing, but these are the disorders which should be kept in mind whenever we see a micrognathia and post-axial polydactyly, which is a Meckel syndrome, orofacial digital syndrome, and short-tip polydactyly syndrome, which are the ciliopathy group of disorders, and Smith-Lemli-Opitz syndrome, which is a cholesterol metabolism defect disorder, bronchio-oculofacial syndrome, and acrocallosal syndrome. So fetal micrognathia, when it is isolated and we do microarray, if it is normal, we cannot tell that the fetus is completely normal without a genetic diagnosis. Sometimes monogenic etiology is most likely, because in isolated fetal micrognathia, the minor abnormalities which cannot be detected in the scan can be found after the baby is born or after the couple terminate the pregnancy. So fetal autopsy evaluation is would give some clues to the diagnosis in such cases. And whenever there is isolated micrognathia, we should discuss about the postnatal complications. Even if the microarray is normal, like there could be some mild to severe upper airway obstruction leading to respiratory distress and feeding difficulties after the birth, though there is no genetic etiology, and the prognosis might be guarded in those cases. So if you look into the approach of case with the micrognathia, whenever we actually micrognathia can be seen even in the first trimester in the lateral view, and when there is isolated or associated with other abnormalities, then the first tier of testing is chromosomal microarray. If chromosomal microarray is normal, then we do the TIFA scan and see if the micrognathia is associated with any other evolving abnormalities. So if there are any other evolving abnormalities, then whole exome sequencing is recommended, or whole exome trio is should be done. So if that is abnormal, then counsel the couple accordingly. If TIFA scan shows isolated micrognathia without any other abnormalities, then we should consider giving the couple option of whole exome sequencing. If the couple declines the further testing, then at least we should do follow-up ultrasound or fetal MRI to know the airway obstruction, exactly whether airway obstruction is there or not. Even the presence of polyhydramnios sometimes gives a clue that there might be a airway obstruction. If there is airway obstruction, then the couple should be told that the child may need ECMO after the birth, and there could be guarded prognosis. So these are my references. Thank you.
So thank you, Dr. Gayatri. So Dr. Gayatri has wonderfully covered actually the whole approach to fetal micrognathia. So Dr. Neelam, you can start the slides. So what additional I would just say is that basically for any anomaly, this is true that we first kind of need to understand on scan whether it's isolated or is it syndromic. So as she mentioned, so these are the broad categories of where you can classify. If there is fetal micrognathia, usually, in fact, majority of cases would be having associated findings. So that's another important point. So isolated are only 15 to 20% actually. The rest all will have something. So you really need to look very carefully. And most of the time you will be able to divide them on the basis of other findings into these four broad categories. So, but then still, if it is looking isolated antenatally, again, we need to remember there is enough literature which says that these apparently isolated ones are actually, majority of them would have additional findings after birth. So again, most of them on scan, they may be looking isolated to you, but they may actually be part of a syndrome. So this micrognathia, as she mentioned, so most often it is not a normal finding. Unlike orofacial cleft, there we saw that 70% were non-syndromic with a good outcome. Whereas if you see micrognathia, then you should be more wary that this is likely to be a poorer prognosis outcome. So I would like all of you to go through this wonderful paper. It's a wonderful review by Dr. Palladini, where he has really presented, we can change the slides, I think. He's actually listed out the various, under all those four categories, what are the conditions and what are the findings you can look for during scan. So these are potentially detectable in utero findings. So various syndromes, next slide, various musculoskeletal conditions presenting with micrognathia. What are the additional findings you should look for? Next slide, what are the various chromosomal abnormalities, microdeletion, microduplications presenting with micrognathia? What are the other findings potentially detectable on scan antenatally? Next slide. And finally, the fourth category of various other genetic syndromes. Even here you can see some teratogenic syndromes also presenting with micrognathia. Next slide. So the most important thing again is to remember that this could be part of so many genetic conditions, and in fact it's more likely to be syndromic than isolated. So you need to be really more careful. And this is from the same paper by Dr. Palladini. He's shown these wonderful pictures of babies with micrognathia, and you can see all babies are not the same. They are different, and actually all of them have different genetic syndromes. So he has in fact listed the individual condition for each of this baby. So this is a really wonderful paper. Please do go through it. Next slide. So finally, in this situation, to say it is really isolated, always do both microarray and exome sequencing. Once both are negative, you can say, yes, this is isolated micrognathia. Then, as Dr. Gayatri mentioned, please assess the airway. And depending on the airway, depending on how severe is the glossoptosis and all, you then please refer to the plastic surgeon who can discuss with the patient about the postnatal outcome and the repair options. And of course, again, neonatal management also will be something you have to discuss with the family. So I think with this, we can finish this particular anomaly, and we can just move on to a little more kind of, we can say, subjective findings. Dr. Neelam, we can move the slide. So this is basically some non-specific dysmorphic features, which are not really anomalies, but sometimes, most of the times, you will not maybe look at them like that. May be not the first finding you see. The fetus will have some other finding, and then you look at the face more carefully and you may see some additional features. Sometimes these can help us in making some specific genetic syndromic diagnosis. So we'll just see some cases. These are more subjective things, and we don't have enough literature on this, but then this is also something interesting which we can focus on. So Dr. Neelam, I think you can start with the case.
Yes, ma'am. So now we will discuss some cases. So coming to the first family, the couple is third degree consanguineously married, and this was the first pregnancy, and they were presented to us with abnormal fetal skeletal findings in scan at 29 weeks of gestation. So on the fetal scan, there was mesomelic skeletal dysplasia with absent femur and absent forearm bones, and the centiles of the bones were up around between -3 to -14 Z score. And in the scan finding, we can see the facial dysmorphism was noted in the form of big nose with prenasal edema, retrognathia, and with these facial findings and significant mesomelic skeletal dysplasia, the diagnosis of syndromic limb reduction defect and possibly Roberts syndrome was considered. And then couple decided to terminate the pregnancy, and they brought the baby for fetal autopsy. And here also we can see the facial findings. Like here the baby is having dolichocephalic head, short forehead, arched eyebrows, overhanging columella, tented upper lip, microretrognathia, and abnormal folded large pinna. So these were facial findings were there, that like what we noticed in scan. There was significant mesomelic shortening, and additional finding that was noted was penile hypertrophy. With this finding, the diagnosis of Roberts syndrome was considered strongly, and we did exome sequencing. Whole exome sequencing confirmed the final diagnosis of Roberts syndrome, and pathogenic variant was detected in S42 gene. And then family counseled accordingly. This is the autosomal recessive disorder. Now coming to the second family, this is third degree consanguineously married couple, and this was third pregnancy of this couple. From first pregnancy, they had a healthy 3-year-old girl child. Second pregnancy was terminated in view of skeletal dysplasia, and the third pregnancy also they were referred in view of some abnormal scan findings at 24 weeks of gestation. Scan was done, and here we found there was significant mesomelic shortening of long bones. Here we can see ulna centiles were -8 Z score. Radius was also at -8 Z score. Tibia and fibula were also very short, -4 and -6 Z score. And all other factors were suggestive of non-lethal skeletal dysplasia with significant mesomelic shortening of long bones. In coming to the facial dysmorphism, here we can see the baby is having frontal bossing, relatively mid-face hypoplasia, hypertelorism, and there was everted upper lip. So considering this facial dysmorphism finding and significant mesomelic shortening of long bones, the final clinical, after ultrasound findings, impression was Robinow syndrome. And Robinow syndrome, we know there is no intellectual disability, and this is a non-lethal skeletal dysplasia, and they usually have short stature. Family was counseled accordingly, and they finally decided to continue the pregnancy. And then the scan, the additional finding was vertebral segmentation defect was also there in thoracic vertebra. Here we can see. And then they continued the pregnancy and they brought the baby with a neonatal evaluation. And here we can see the facial dysmorphism finding, like the baby is having relatively large head, frontal bossing, wide open anterior fontanelle, flat face with mid-face hypoplasia, hypertelorism, upturned nose, like that we notice in the scan also. Here we can clearly see the upturned nose, and then proximally placed thumb, and some digital dysmorphism was also there. And there was, here we can see the significant isomesomelic shortening was there. In the X-ray findings, we can see mesomelic shortening of long bones. Here and here also we can see this is humerus and radius ulna and femur and tibia. Here we can see. And all the prenatal findings were confirmed on autopsy and skeletal examination. And the diagnosis of Robinow syndrome was considered. And exome sequencing was done, and we found that confirmed the molecular this diagnosis. And we found the likely pathogenic variant in ROR2G, and that diagnosis of Robinow syndrome was confirmed. Coming to the third family, this is third degree consanguineously married couple with they presented to us at 27 weeks of gestation with previous 1 3-year-old healthy child, and one pregnancy terminated in view of cardiac and CNS anomalies. And they brought the baby with fetal autopsy because in the scan finding they were told that absent corpus callosum was there. And in the fetal autopsy finding, there was significant microcephaly, sloping forehead, big nose, and subtle bird-like faces were there, and large ear were there. And there was ectopic hypoplastic right kidney and absent corpus callosum, and cerebral hemisphere fusion was there. And exome sequencing was done, and the diagnosis of there was biallelic frameshift variant in pathogenic variant in C, E, and PG gene, and that is associated with Seckel syndrome 4. So that was the final diagnosis for this family. And then they came in the fourth pregnancy with because we had the molecular diagnosis, so we advised them for prenatal testing in the next pregnancy, and they came to us in fourth pregnancy. And the scan, they came for chorionic villus sampling. The scan was done at 13 weeks of gestation, and here we can see at 13 weeks only there was slight abnormal forehead was there. And then chorionic villus sampling was done, and sample was sent for targeted C and PG gene variant testing. And then repeat scan was done at 17 weeks of gestation. And here we can see in the baby who are having the similar facial finding like the previous baby. And here we can see the sloping forehead. Microcephaly was there. Here we can compare the BPD was diameter was less, 2 week lagging behind the POG from the LMP and CRL. And here was this microcephaly, big nose, and retrognathia was noticed. And the targeted variant analysis was also confirmed that fetus was affected. And family counseling was done accordingly. This was the fourth case, and this is the first child of third degree consanguineously couple. The child was presented to us with global developmental delay and had some facial dysmorphism, like here we can see the partial alopecia, tall forehead, microcephaly, absent eyebrows, and there was large tongue. And the molecular diagnosis for the baby was GTP-B2 gene associated Jaberi-Elahi syndrome. This is a very rare syndrome. It's an autosomal recessive condition, and very few cases are reported in literature. And then they came to us in second pregnancy for prenatal testing at 17 weeks of gestation. Amniocentesis was planned, and the scan itself, you can see the baby, this fetus is having the prominent frontal bossing and tall forehead. And amniocentesis was done, and that confirmed the fetus was affected. And family counseled, and they decided to terminate the pregnancy. Shagun ma'am will discuss further.
Yeah. Thank you, Neelam. So basically, facial dysmorphism, again, it's mostly a very subtle finding, but then if we start looking more carefully, often we do find some fetuses with these kind of abnormal facial profiles. Some may be very subtle, sometimes it may be striking also, like in cases with geniosynostosis and all. So in here, like in these 4 cases, the first 2 cases, we saw the dysmorphism prospectively, and it actually helped us to narrow down to the diagnosis also to some extent, especially like in the second family, we could tell them that the baby probably has this condition called as Robinow syndrome, and putting together all the findings and the facial features also, and that is what it turned out to be, and it actually helped the family decide that they wanted to continue the pregnancy. In fact, the molecular testing was done after the baby was born. So this kind of and the rest of the 2 cases, of course, we saw the findings, but then we were looking more carefully because we already had a previous baby where we already know how the facial features look. So these things are somewhat difficult to often appreciate. But then again, we usually as geneticists, we do like to look at this because we already like know the postnatal, we see children, we see adults with dysmorphism. So in the scan also often we can appreciate these features. So in fact, we have recently published this work also, and this is what Dr. Neelam's thesis was on, where we did a scan and then we followed up these cases. We also did autopsy, and in some cases, 5 cases, the family continued the pregnancy and we saw the babies after birth. And we actually found that in scan itself, in around 40% of these cases, there was dysmorphism, which was actually confirmed later on autopsy or on neonate evaluation. But then, of course, we were not able to appreciate in all.
You got muted, Shagun, you got
Sorry,
muted.
sorry. Yes, yes. Dr. Neelam, next slide. And then there was also, of course, a difference in the kind of dysmorphism. So in the sense that what kind of features were easier to detect. So like things like something like abnormal skull shape or mandibular abnormalities, spacing of the eyes or nose, the philtrum, and those things were relatively better to appreciate. So these blue bars are the cases, number of cases where we picked up on scan the dysmorphism, and the red bar are the ones on autopsy or after birth. So of course the red bar is much higher, but then still in some cases we are able to see the dysmorphism, but certain things like ear findings we were not able to appreciate in any case actually. And some other things like very subtle findings, abnormal, coarse facial features, and some other things are not easily appreciable. So this is just our experience, what we have seen ourselves. And but you can see in literature also, next slide, there are reports, mostly in case reports and case series where people have reported finding, next slide, Dr. Neelam, where people have reported that they are able to appreciate some specific genetic syndrome on the basis of the dysmorphism that they are seeing on the ultrasound. And in fact, some of them involve more of 3D ultrasound. We'll go to the next slide. Okay, so this is just to kind of bring an end to this part on dysmorphism. We don't really have a case on ear anomaly. So, but then just to put in a word, so again, ear anomalies are again little difficult unless we are looking for them, of course. But we do have percentiles also available for the ear length, and we can pick up like microtia, that is smaller ears also. And then there are various genetic disorders associated with ear anomalies, and most of them do have associated hearing loss, and also many would have associated malformation. So again, if you have ear anomalies, think of investigating for various genetic conditions to prognosticate the family better. Here sometimes there may not be associated malformations also, but many of these children can have hearing loss. So it's important to again still investigate irrespective of whether there are associated malformations or not. Next slide. So again, so just to kind of summarize this aspect. So if we have any kind of prenatal imaging abnormality, we can also try to look at the fetal face and try to see certain dysmorphic features. Sometimes we will be able to make a specific syndromic diagnosis. This does help us in prognostication, as happened in the case with Robinow syndrome. It also helps us in choosing the correct genetic test if you have cost and time constraints. So you can decide whether you want to do microarray or you wanted to do exome sequencing. And then at times, if you already have a diagnosis known, you can prenatally also pick up certain features. So finally, I think to conclude from our side for this session, so we could say that the fetal phase per se, we have seen last time also and this time also. So there can be a wide spectrum of abnormalities on imaging. Sometimes it may be an overt malformation, sometimes it may be a more subtle finding, and they all have a very variable outcome. So we need to be aware of the genetic association of the various different findings, because once we know that, we know what else to look for in the scan also, and then this can help you in reaching some kind of a differential diagnosis, and depending on that, then you can choose the genetic testing also. Ideally, if there is no time constraint, no cost constraint, of course you should do a complete workup, so which includes a microarray and an exome sequencing. But this is an ideal scenario. So in the second session, we are going to discuss the practical problems which do arise, of course, in the clinical settings. So, but then again, just to reiterate, this testing is important. More important, sometimes you can say, in cases with apparently isolated findings, because that is the case where you don't want to miss a baby with something which is not there on scan. So you should encourage them for complete genetic workup, because then only you'll be able to prognosticate them properly and they can take a decision. And then, of course, even if there is a severe anomaly, they terminate a pregnancy, still the genetic workups is important, because that helps in recurrence risk counseling and providing prenatal testing or pre-implantation genetic testing in future pregnancies. So I think with this, we'd like to conclude this part of today's meeting. That is our first session. And then probably after trade partner videos, we can go on to a more lively session of where we can have actual discussion with the experts.
Like a marathon. We've had a marathon run on the face. So we started with imaging, then we went on to the anomalies of the upper face and then anomalies of the lower face. And Dr. Shagun has presented very comprehensively how genetic workup is very important when you see these anomalies. Now, this is all very good in theory. We are back to practical problems where each one of us is going to image the face every day, and each one of us is going to see some of the other problems. So some of the experts that we have today come from the core areas of pediatric surgery, plastic surgery, and genetics and fetal medicine. So we will summarize all what we have learned in the last 3 sessions and take home some very strong practical, practice points, so that we are not more confused after this program than before the program. So I call on board Dr. Parvati, who is the head of the pediatric plastic surgery unit in Nizam Institute of Medical Sciences and does a yeoman service on the treatment, postnatal treatment of the cleft lip and palate babies here in Hyderabad. Parvati madam, I saw you there and I hope you're on board here. And Dr. Kaushik Mandal, who is a geneticist from the Sanjay Gandhi Institute of Postgraduate Medicine and Sciences. And he works into core clinical genetics. And we have Vimal Sahni sir here, who is like a hardcore fetal medicine person who deals with these practical problems of answering the patients, answering the queries of the parents after diagnosing these problems. So let me start with Parvati madam, because there is a question here on should we be using the Tessier facial cleft classification. So madam, I want you to tell us what is it that you want an information from the prenatal imaging people to make your plan for the future. So how much detail do you actually need from us in prenatal imaging for making a plan for managing the babies with facial clefts? Please unmute yourself, madam.
Sorry. Actually, most of these facial clefts doesn't need immediate surgeries. They usually, if there is the requirement for surgery depends on the type of the cleft and what are the functional problems, what are the skeletal problems, and all these procedures are staged. For say like functional problems like eye is exposed, or there is a respiratory distress, or there is a difficulty in feeding and the breathing difficulties. Probably that is the area we try to operate early. That is about 3 months to 6 months. Okay, then we have skeletal abnormalities where we need to put some bone grafting and all those things. And there are some areas where we have to do surgeries in the adult age. So it all depends on the cleft location, like the midline clefts, lateral clefts. So it all depends on, I mean, the location, which is classified into 14 tissue clefts, facial anomalies. So it all based on the location of the cleft.
So do you want us, like, why we are asking? Because the majority of the crowd here is fetal medicine people who do antenatal
Yeah.
imaging, prenatal imaging. So once we have detected a cleft, is there anything on our finding which is going to tell you that I don't want this pregnancy to continue? Or is there anything in our finding which you want specifically this answer so that you can prognosticate it for the mother? Or you feel it's okay, whatever it is, continue, I'll see after the baby is born?
No, I don't think that is the criteria. It all depends on the measurements what you are taking. For say hypertelorism, intercanthal distances and wide clefts, the micrognathia already what you have discussed. These are all the areas where we need the measurements actually. For example, micrognathia, what we look for is maxillomandibular discrepancy. Usually we see if it
Correct.
is more than, yeah. So the measurements are more important so that we get prepared for the procedures what we have to do. Like immediately, the most of
So
the
you
times,
need
some measurements where we can plan for the surgery. For example, micrognathia is the most difficult situation, respiratory obstruction. So there, immediately it's a algorithm kind of thing. Immediately the positioning of the child, then we go for nasopharyngeal, I mean, tubes. Then we think about lip adhesions and distractions kind of things. It all depends on the severity basically. So the discrepancy is one thing, and how the child is picking up. Some children may pick up immediately after the neonatal period. Some may not cope up with the. So then we have to plan for distraction. So when we plan for distractions, suddenly if the child is in distress and we don't find any distractor, that is the time we need pre-antenatal measurements, which can help us the size of the distractor, what we can apply. Such kind of things probably help us. That is what I was about to
so
ask you.
specifically in cases of micrognathia, you would expect a
Yes.
lot of detail from the
Yeah.
antenatal, but just plain clefts and palates, you're okay with
Yeah.
just giving the diagnosis of a
Wide
soft and a
clefts
hard palate?
also. Yeah, cleft lip and palate we can manage. Even with wide clefts up to 2 centimeters also I have operated. We can manage with cleft lip and palate. That is not a big issue. The issue is where we have respiratory obstruction. That is, we need more inputs from you. That is the area we are looking
Okay.
for, your
So
inputs.
Bimal sir, yeah, thank you, madam. Yeah. So Bimal sir, there is a question also there that can we assess the fetal airway in antenatal scans, and what will be your approach? When will you start worrying and giving the pediatric surgeon a lot of detail regarding airway obstruction in cases of facial anomalies?
When you're see, as such, you have all secondary signs that you're going to get when you're suspecting an airway obstruction. Now, if you have the lungs appearing hyperechoic, because there is fluid accumulation that would lead to the lungs becoming more echogenic, and that is the time when actually once you start getting them to be more echogenic, you can actually look into the trachea and the bronchus also. But for me, I think these are all very things which, especially in cases of micrognathia and all, we're not expecting these kind of scenarios. Maybe polyhydramnios would give us some clue that yes, there is an issue with the swallowing, so that also would be an additional finding for them. But
So
other
objectively, we have very few clues, and because high airway obstruction per se, Of course, if there is an airway obstruction, you will have echogenic lungs and things like that. But something which is developing secondary to, poorly developed lower face, and then, the tongue retracting and things like that. The clues are very little.
Very little.
Yeah, we need to progressively look into that, and whatever information we can give, we can provide it to the this thing. So there is a question about MRI. Can it help in the diagnosis of airway obstruction? It would be a very, I mean, it's not yet a very reliable method of confirming an airway obstruction, but suffice to say that when you see severe micrognathia, that is something which worries the pediatric surgeon and the neonatologist more. So please be mentally prepared for a need of an exit procedure and the need for immediately establishing an airway post-delivery, because your objective parameters may or may not work every time in terms of airway. If you look into the literature, there are, papers about seeing the fluid in the trachea move. There are papers about reconstruction in multiplanar imaging. But honestly speaking, we don't have any objective method to say that, but there will be a high index of suspicion when you see indirect signs. And it is better to be prepared for an exit procedure with the neonatologist and the person in charge of putting in an airway in a newborn baby.
Dr. Chinmayi, can I ask you a question? Yeah. Actually, when we do distractions and all those things, when we do skeletal surgeries, we use a lot of 3D printed models. Is there a way where we can have a 3D printed model from the images, which can help us in guiding how to plan the vector and things like that? Is it possible?
Yeah. We are reaching there because there is technology available to get a 3D image and a 3D printing done. But again, it's still currently being used for like rendering, surface rendering type of issues. But I think if we work on that and see how that is exactly going to help you in terms of planning your surgery, it's a very potential area for us to put our efforts in and try and get that done for a few cases and see how it works. It is possible, technology wise, it is possible. And even in India, I think the machines are offering that facility. But the cost and the ability to get that image straight away is a little bit of a limitation at this moment.
No, it is not so costly. Actually, we do it regularly for craniofacial anomalies. The thing is, we are well prepared for the surgery. That is the advantage. Because the child...
So the way we look at, you see, madam, what will happen is when postnatally that drawing and the rendering can be available to you, will it make a huge difference to you to have that antenatally for you to prognosticate whether or not this baby should be allowed to be born? So we are talking about a time around 24 weeks. So would a 3D rendering and a 4D picture like that give you enough evidence to say that this is definitely going to be a problem and hence this pregnancy needs to be terminated? Because that is where the dichotomy is. So if we can, if the baby is anyway going to be born, you can do whatever you want after the birth of the baby. So in prenatal imaging, is there a role of doing this so that you can take a decision of discontinuing?
I don't think that is the time we can take the model and plan for it.
So that is why I think what is more important for us antenatally is to just establish what is the problem and maybe rule out the other associated features so that the postnatal outcome is optimal. So Dr. Kaushik, that is where I'll call you in. So, we talked of so many genetic tests, and in an ideal setting, we'd like to do all of them. But there is a turnaround time for each test. These fetal anomalies are detected somewhere around 18 to 20 weeks when we do the anomaly scan. So how would you, plan realistically the genetic tests in any case? Because if everything is normal, we want to say that this is an isolated problem, not an issue.
Yeah, thanks for the question. One thing I wanted to comment, and I was waiting for this, that we cannot underplay the importance of teratogens in facial clefting. Because maybe fetal alcohol or smoking is not that important, but a mother on valproate or antiepileptic drug they definitely has a propensity to develop clefting, and it is a thing which is so much preventable. And what we think are non-genetic cleft lip palate does not mean, or non-syndromic cleft lip palate does not mean that there is no genes involved. So many of them will be discovered with time that there is a gene involved in the process of clefting. So these two are important, and a good phenotyping here the importance of a fetal medicine expert comes. A good phenotyping will help you guide what we should do or the what is the test to be done. Probably, and it is also true that along with microarray, chromosome should be done, because you know you are seeing multiple anomalies, like the heart is involved, the limbs or digits are involved, you are seeing clubfoot, you think of trisomy 18, right? You are seeing anomaly of the ear, you think of teacher colon with micrognathia. You are seeing absence of mandible. There is a very interesting mm, syndrome called agnathia autocephaly syndrome, where there is mandible is absent or very small, and they have ear. The ear is also not there, and it is a though a rare genetic disorders, but you can diagnose that, or you can find it. It's a single gene disorder, right? So there we proceed fast with single gene testing by maybe exome, or if it is a small gene, we can do a Sanger sequencing.
So what would you recommend? We had one of these autocephaly cases which we diagnosed, but all we could manage was a postnatal photograph, because that's all. Once you tell them the prognosis is so bad, they eventually just terminate and do not want to do any testing. So if you have micrognathia and nothing else, and you don't see that the parents have similar facies, what
And
would you recommend as the first line of test?
and you also have ruled out a cleft, underlying cleft palate, isolated cleft
Yes.
palate, because Perry Robbins is fairly common. And then you start seeing or thinking of disorders which might lead to a cleft palate. So in that case, probably a straightforward will be a microarray, but a normal microarray should not guide us in telling the couple or the parents that there is no genetic disorder, right?
So I think what Shagun was also alluding to, and what you're also saying, is if the microarray is normal, then probably proceed to a exome sequencing.
That's true, but even if exome sequencing is normal, there will be so many genes which might not be covered. And again, I am telling that it's phenotyping. Probably here the fetal medicine people will come into play, and they have a big role to play. That a good phenotyping, like measuring of the bones, whether there is really a mesomelia associated, right? So a good phenotyping by a fetal medicine expert will be very helpful in interpreting the results of whatever it is, microarray or exome.
So to bring it for the benefit of all our audience here, what we are trying to say is, once we see a facial anomaly, you characterize it as much as possible. So if it is a cleft or something, then you may take your measurements and do that. If it is isolated micrognathia and it is severe, then you're thinking in terms of the functional disturbance at the time of delivery and prognosticating it on that basis also. If it is a mild dysmorphism, you are not sure what this is. So you will offer a microarray. If that is normal, you'll probably offer an exome sequencing. But then at any stage, you're not in a stage to say that this will be completely normal. Now, Bimal sir, after this counseling, if the patient says, no, I don't want to continue the pregnancy, do you consider this as a progress, or do you consider this as a regressive issue?
No, I am neither progressive nor regressive. I think, see, when if you tell them all this, like Dr. Kaushik has said, that in spite of this being normal, also there is a possibility of, the exome telling you something. Even if exome is normal, there is still a possibility there could still be some genetic thing which we don't know of. So when you see, I have realized the more you counsel, the more patient goes towards termination. So, I feel in practice, There are two, usually I think somewhere down the line, we decide ourselves whether this patient should go for termination or not. Let's be very honest. And then we start talking in that line itself, because you can counsel the whole thing at one time, or you can do this sequential counseling that you say, okay, we get this microarray done. Now this is okay. We have not found anything in this. Now we need to do the next one. So maybe stepwise. But then again, the time
Time is
factor.
again not in your favor, sir. Yeah.
So I think the most important thing which has come from Dr. Kaushik's statement is that you have to, when we say phenotypically or on ultrasound isolated, you better be sure that it is isolated. So the whole thing is that you really have to extend your protocols, and not, even if you see a facial abnormality, yes, but even if you see some other abnormality, face becomes a very, very important thing, because dysmorphism, facial dysmorphism actually changes the complete the syndromic diagnosis also. So you may find something very, very lethal in the heart, or some or in some other parts, but if you add the a good evaluation of the face and the facial abnormality to that, the syndromic diagnosis is going to change. So both ways it is important, and I would say yes, parents do have a right to decide. So uh, so there are two things, Chinmay, in practice. There is something called giving information, and there is something called insisting on something, and that we do in our own, wherever we really feel that yes, this baby can be given a chance. There is a little extra pressure from our side, like, okay, let's get this done. If this turns out to be normal and the other two tests come out to be normal, this baby can have a very good outcome. But wherever we ourselves feel that no, this may land them into a lot of problem, we do inform them, yes, these are the things, but we don't insist on them. Otherwise, normally also we are not supposed to insist, but there is a difference in our tone when we say the same thing.
Yes,
So
on the
at the
flip,
end of it, what I think all of us, yeah, Dr. Kaushik.
yeah, on the flip side, I start feeling helpless when I don't make a diagnosis, right? And
No,
this is
you're very
what
right.
Dr. Shani, this is what Dr. Shani is telling, that we become authoritative ourselves what to do for the patient. But it's true, when we make a diagnosis, we tell it correctly. This is very likely to be trisomy 18, and these things are there. And when there is associated mental subnormality in your diagnosis, according to your diagnosis, parents have all the rights to get the baby terminated. See, anomalies
True,
can
very
be
true. The
solved.
point is, when we are not sure, that is where the problem is. Like, suppose there are multiple features, like you said. I think one of the important things which we have to understand is, after this whole discussion on the face, the checklist for the face doesn't end with the face. So after you've seen something in the face, you have to see the brain in detail, you have to see the heart in detail, you have to see the bones in detail, you have to see the spine in detail, and you have to see the movements in detail. So the checklist for any anomaly, in fact, this is just a reiteration of what we've learned otherwise also. You look for one marker, you find one marker, you look for all other markers. So similarly, anything that you find in the face mandates that you go ahead and look for everything else. So if we were going to make the checklist, we thought at the end of this session, we'll have a checklist for what all to see in the fetal phase. But now we are realizing that the checklist is extending all over to the baby over again, so that, like Dr. Kaushik said, the phenotyping has to be really good. And then only you can think of some specific genotyping. So that is like the thing, but still, because we need a checklist, Bimal sir, what all would you think is enough for a regular imaging person to do in first trimester and second trimester?
As far as the face is concerned,
Yes.
yeah, okay, I would have my axial, coronal, and the mid-sag view. These are the three planes that
Axial,
you have
coronal,
to,
and mid-sag view.
yeah, you need to, and you need to, you look for the nose and the upper lip,
Prenasal triangle.
and also the prenasal triangle, And if you make it a habit, it also becomes very easy that somewhere during the scan, the fetus does come in a position where you are seeing the face up, and then that one single sweep gives you the alveolar ridge. And if you, with little bit more of experience, then you start even seeing the palate behind, you're able to make out the tongue. So and at times during the scan, if the fetus opens the mouth, then in fact the smaller clefts and all become more easy. So you, as a routine, you're not venturing into anything very different. But now once you have suspected, then of course the scan extends. Now you are thinking in terms, or even subjectively you feel that okay, there appears to be a retro or a microagnathia. Then you go about doing all those indices, the jaw index, and all those measurements, and maybe give some kind of an objective dimension to your diagnosis also. You feel
So
of the facial.
should every case of facial dysmorphism be referred to a clinical geneticist?
If I'm very sure about the diagnosis, I may not. But wherever I'm not sure about the diagnosis, I would want somebody else to become a part of it. And I think, and especially if it is, there is significant syndromic this thing, then fine. Anyway, the diagnosis, more than the diagnosis, the outcome is not changing. But if I have a very, very subtle finding, if I have something which is an isolated thing, for that patient, whether to continue or not would also depend upon what is the etiology, what is the genetic association. So definitely would want
Are
a
the
genetic.
geneticists happy? See, where there is a complete problem, multiple problems, all of us know outcome is bad, we'll all say the same things. If it's a very subtle dysmorphism, are the geneticists happy to be referred to every time? Because we will be looking towards you. Whatever you say, we'll do that.
It's true. In our country and setup, we don't have the luxury to have common clinics, right? But it's definitely very, very helpful. I have been into common clinics in CMC. We had a perinatal clinic, we had a development pediatrics clinic, and also in SGPGI, we try to have a team who will look at. See, when we look at a disorder, whether it has got anomalies, the number of anomalies, how to treat it after the birth. So we will have pediatric surgeons, we have plastic surgeons. We discuss among ourselves how to treat it. But in our country, the number of patients is so high, the doctors can spare so little time. So the practical solution is what Dr. Shani is telling, right? The practical solution is this, but definitely we need joint clinics for each of these, whether it's a known multiple anomaly, trisomy 18, or it is a very rare, subtle, small retrognathia. To deal with it, for all these patients, we need joint clinics. We need inputs from various people, including surgeons and geneticists, fetal medicine
So I
experts,
think even
radiologists.
if a joint clinic per se is not possible, like we do, we just refer them to the genetics unit in NIMS, and they go there and talk to the geneticists themselves. They get the opinion and they come back. So it takes about a day altogether, but at least they get the opinion of another specialist in the same area.
But joint clinic is something which is far beyond this, what we are doing, what we are practicing. That
True, very true. In an ideal setting, we'd all like to have that. But then again, we have to live within our resources and within the, especially this public-private disparity which we have. We really need to work within the framework that we have as of now.
The biggest
So
advantage of having a joint, even multidisciplinary counseling together,
correct.
see, it because the case is already discussed, and then the best part about that is that everyone is speaking the same language, because there has already been a discussion on that. See, what we are doing at the moment, yes, that is the only thing possible. But then it does happen that at a primary level, I have said something, then the geneticist on their part has said something, the pediatric surgeon on their part has said something. And I think at the end of it, the patient gets far more confused than really getting, because they come back and they say, "Nahi, unhone to, they told us
Yes,
this."
correct.
So,
The surgeon tells that it is so easy, we can operate on you. The geneticists tell that no, it is something which will have mental subnormality. The fetal medicine expert tells, see, there can be other anomalies associated with this. So
I've
definitely,
never, I've never, all my patients who've gone to a pediatric surgeon, they were always told, "Ki I've done 4 cases of this kind, and they're all doing well." So, uh,
So, to the pediatric surgeon, madam, how many times have you faced the problem that antenatally you have assured them, but postnatally there have been other issues like genetic issues or other problems because of which the outcome has become bad, not structural, complications.
Dr. Chinmay, you are asking me?
Yes, yes.
As I was telling, I don't think much of the cases will have complications or anything.
So I think, like what you're saying, madam, this is like the clubfoot dilemma that we have. These are some anomalies where I think luck also plays a factor, because
Cases will be able to manage cleft lip and the mortality kind of things at the time of antenatal imaging. That is more important. Am I lost in between?
Yes, in between
Hello?
we lost
Yeah.
the audio. Mhm.
Okay. What is more important is what is the morbidity the child is going to have? What are the issues the parents are going to face? For example, micrognathia. So that is more important when we discuss with the parents. Coming to the surgical part of it, most of these cases can be operated. We operate perirobin sequences. We operate on craniofacial clefts, syndromes, and synostosis, and all those things. The outcomes will be good. I don't think this is something that parents should be very much afraid of. That is what I feel.
Just to add,
Unless it is life threatening, or the child is having too much of morbidity to carry on with his life. Probably.
So basically, as a surgeon, you don't have that much of an issue
Yeah.
managing the structural problem of it, but the final outcome will depend on the genetics. But again, as a surgeon, you don't feel that much that genetics comes in the way of your treating the patient. But antenatally speaking, we are putting a lot of thrust on genetics, and for good reasons, because detecting. But somewhere I feel you just have to be unlucky to find something very, very problematic. Like the question has just come: what are the medico-legal consequences of missing facial dysmorphism? So it just has to be one unlucky doctor, unlucky patient scenario where you thought that, okay, it's just mild facial dysmorphism, may not happen. And then it turns out to be some very, very unusual and rare kind of syndrome.
yeah, subtle findings are definitely subtle facial dysmorphism antenatally may be very difficult to appreciate. When they see it postnatally, it looks too obvious, but prenatally it may not look that obvious. And
That's what is
especially,
the medico-legal consequence? So as an expert, if you are supposed to opine on a situation like this, where there was some subtle facial dysmorphism and the baby turned out to be having some very, very rare genetic condition later on. As an expert, what would be your opinion? Dr. Kaushik, Dr. Shagun?
See, we always counsel in the lines of likely to be, very unlikely to be. Then we will always write in during scans or during counseling notes, what are the percentage of anomalies which can be picked up, what are the percentage of anomalies which are missed. And we also should discuss, we'll write definitely, so that will save us from all these medical legal issues. And we should also discuss with the parents not to uh, uh, lose their trust on doctors, but just to make them aware that there are some unlucky things which might happen.
True. And
I would add, no, I think we can use some, empirical figures for counseling here. That also becomes important.
Yes,
Because
in
already,
percentages.
as we know now that even despite all genetic testing, we may not, of course, reach a final answer or 100% answer for any case for that matter. So, yes,
so that is one of the comments that we have got, that the person is not named here, but it just says that it's an iceberg phenomenon because most cases
Yes.
which reach the pediatric surgeon may not be having genetic conditions or multiple anomalies, because
In
those are
fact,
the
I
ones
wanted
which
to,
land up.
yes, I wanted to make this point
Uh,
also because many of these because of pediatric, it is kind of an ascertainment bias kind of a thing, right? If they're reaching the surgeon, of course, these are the ones who are not lost in pregnancy or not lost at birth. So obviously, I mean, they are. I mean, the surgeon may not see the ones who have other problems, but
problems.
antenatally, that
Okay.
is a
So
trick.
thank you, Purnima,
That's the
madam.
tricky,
She is
yeah.
made that comment. And the other question here was a bit unrelated, but because we are running out of time, let's just finish that. Please throw some light on PGTM. Is it more sensitive than microarray? And what is the reliability of this technique vis-a-vis microarray? How much does it cost? So PGTM, I think, is something which we will do as a pre-implantation genetic testing when we do an IVF. So if we have a known genetic syndrome, that is when this technology will be used. So Dr. Shagun, Dr. Kaushik, anybody wants to just
Is it for
answer
a
this?
it's meant for a single gene disorder or a chromosomal anomaly?
Yeah, I think that's the confusion here because Shagun had mentioned both in her slide of the conclusion. But you see, these are two different things because when we are doing PGTM, we are doing for a single gene disorder. And when we do microarray, we are looking at chromosomal abnormalities. So microarray is like a high resolution karyotype there. And this PGTM is for single gene disorders in IVF. I think we'll do one on genetic techniques at some point. We'll have a class so that we can
Yes,
aggregate
yes.
these things.
Just to throw light, a small light, which I had understood about this, that even if you do a PGT for a single gene disorder, it is not the same technique as we do for prenatal testing. So pre-test should be done. Pre-test before the embryo is biopsied and the test is done. Pre-test or a pre-biopsy testing should be done to find out whether this can be picked up or not. It's not the same as we do for all single gene disorders in genetics, like by Sanger.
Think one more thing, probably probably one of the things what Dr. Kaushik is trying to also say that, I mean, for doing PGTM, you basically need make a diagnosis in the family. You need the mutation in the family,
Correct.
and it is for a monogenic disorder. So I mean, there's no comparison with a microarray. I mean, we usually
Microarray is for chromosomal
yes,
disorders, and this is for single gene or monogenic disorders, like you said.
So in a pre-implantation setting, you would be using microarray if you are looking for, you're trying to screen for aneuploidy, or if one of the parent is having a balanced chromosomal rearrangement like a translocation, then you would do a PGT and do a microarray because you're looking for that. But when you are looking for a single gene disorder, then you know the disease in the family, you have a mutation in hand, and then you just look for that in the embryo. So they are two different indications, two different tests. There is no comparison per se. I mean,
Yeah.
cost wise or technique wise as such.
Dr. Anupam is asking pre-auricular tags. How do we deal with them? Bimal sir, how easy it is to diagnose pre-auricular tags?
It's not definitely not easy to see as a routine because we are in fact see most of the guidelines and protocols do not even have looking at the pinna on both the sides as a part of the protocol. Let's be very clear about that because there's a lot of these medical legal problems which are coming because of an absent pinna or a microtia on one side. But maybe expert centers, because they have expanded their protocols beyond the guidelines, then now this pre-auricular tag. So if you're really looking at the ear, you're going to be, and if you're using 3D, you're going to pick them up. Definitely. We've had a few cases which we have appreciated. But what's important is they have a very strong it's not just something which is an extra tag. You have to look for genitourinary and your cardiac abnormalities. They have a significant association with both these things. And so it's not just something that, okay, there is a small tag that if you see that, again, you're moving back to a more detailed scan, looking for, I think it's cardiac and urinary tract. Somebody can add up to that. Or
Yes, yes, correct.
So
Correct.
Also
these tips,
vertebral
yeah.
defects also.
Vertebral anomalies too.
Yes, segmentation.
And here a small comment is that it is always good to write what we have seen in the face and not to write that there is no major anomalies. So I will, during scans, I will not write that there is no major. I will write that orbits are seen, lips are seen, nostrils are seen, like that. So because as Dr. Saini told that there is no fixed protocol, that we don't look at the ear. We generally don't look at the ears if there is no ear anomaly in the previous child, or we have or in the family.
Can I add to that?
Yeah, please, Dr. Parvati.
Clinically, what if we see a preauricular skin tag, we are worried more about Treacher Collins or craniofacial microsomia things, that kind of things. Immediately we look for ear and facial congenital facial palsy and mandibular hypoplasia. That is what I see when a child comes with a preauricular tag. If this simple skin tag, we just excise it. It will be usually pedunculated, very small scar will be there, probably 1 to 2 millimeters. That is not an issue. But the issue is whether it is associated with facial nerve palsy, mandibular hypoplasia, any other craniofacial anomalies which are associated with the hypoplasia of zygoma, maxilla, and all those things. That is the issue. So simple skin tag may not be simple skin tag.
So what we are realizing is it's like opening the Pandora's box, and every time we start discussing any one aspect of the fetal phase, we realize there's so much more to it, and it's not actually finishing, But this time we've decided that the discussion ends with this third session, because we've really had 3 exhaustive sessions on the fetal phase. What we have come to realize at the end is, like when you say face is the index of mind, similarly the face is the index of your scan that you do, and you try your best to see whatever you can. So do your best until you know better, and when you know better, do better. There will be problems because unfortunately it's the fetuses which have growth restriction, which have other problems. Visibility itself is a problem. And sometimes the fetuses are not in the best of their positions. You may have shadows because of maternal habitus. You may have, the hands or the fetal face covered by some bony element which casts a shadow and does not allow you to see certain things. Misinterpretation of the image also is possible. It's not always that you have not done the right job, but you've done it and not interpreted it correctly. So there are lots of problems. Despite all that, I think the endeavor has to be to see as much as we can and keep on updating yourself with all these possibilities, because your counseling at the end has to be a summary which does not scare the patient and does not overtly reassure the patient. So that fine balance is something which we have to learn how to talk and how to explain that. And we will find some things, we will miss some things, but at the end of the day, our aim and intention should be to do the best by our patients as much as possible. So any words of wisdom? Yes, sir.
Just one point. I don't know whether you all face it, you all must have, but I have noticed that fetuses with facial problems generally do not show their face very easily. You know, there's no scientific basis to that, but a lot of times you will
No,
find
sir,
that
these are the patients who have hypokinesia, who have poor growth, less like,
and then they'll have their hand in front of the face. You really have to wait and wait till the time you are able to.
We cannot undo the fact that while you are scanning, you are also stressed by the fact that the moment I mention anything which is other than what is optimal, there is a risk that they may go ahead and terminate the pregnancy. So sometimes your scan becomes the lethal, intervention in that pregnancy. So it's always a like dilemma for the person who's reporting. And now that we know so much can be there, which can be wrong in the face, I'm sure a lot of us have got a little scared of the face, as I would say, because too many things to see and too many things to remember. But that's how it is. Once science evolves, we have to learn more and more and stand up to that challenge.
These 3 sessions have been eye-openers.
And
I told you in the beginning, there is somebody who pointed out that how can they create 3 full-fledged webinars out of only the face? Only they can do it. And like, I think every minute that we spend in the last 3 webinars was mind-boggling, in the sense, this is like true learning. We've taken up, you took up one particular part of the body, and then we've gone extensive into it, and the genetic inputs have been terrific. They were like, most of them were eye openers. The majority of us, even we always thought it is only cosmetic. We never knew that there could be so much more than just the cosmetic part as far as facial dysmorphism is concerned. And we will have to work very hard on the face, because see, the problem is, you miss a major cardiac anomaly, there is no issue, because the parent is going to come to know about it after a few days. Most of the time the baby dies in the neonatal period, but anything which is external is the first thing that they see immediately after birth. So their immediate reaction is very bad.
Comes as a shock, and managing that thing, and especially if there's an association with a genetic condition, then that really becomes very distressing. So
my comment was that it's always good to work in a team, because that saves your night's sleep.
Yeah, my suggestion, can I add? Yeah, my suggestion is, apart from imaging and counseling, I think it is better to send to a surgeon where he can give the options available and all those things. Then the parent can decide whether to go ahead, what are the morbidities, what are the outcomes, and all those things also they should know. Then only they can decide, because just having a cleft lip is not a major issue.
No,
So,
absolutely. And I have to put on record here that Dr. Parvati's team, they not only offer that kind of a counseling, they provide videos of children after they have been repaired. And they really are doing a very, very, constructive antenatal counseling that has really helped us continue our cleft lip palate cases. Madam, I always feel thankful to you, because we have seen a change in the way the patients perceive cleft lip palate after the intervention of their team. So that's
the
definitely.
Surgeons give a positive input and the genetics scare them. You want to tell that?
No,
they have to balance the risks and outcomes.
Correct. Absolutely.
So before we close, I think I want Dr. Shagun, who has been one of the major pallbearers of this series, to just say a few words, and then we'll close the session.
So thank you so much. I mean, I think it's been wonderful for me also to, work with everybody, with Chinmay, and with blessings of seniors, Dr. Bimal sir, Dr. Khurana, Dr. Praveen. I mean, everybody has come together, and we have been able to pull off this, 3 series. Literally, I mean, marathon. The Bahubali. This is, our culmination finally. So I'm just really, I think I'm really thankful for everybody who has been part of this, and all my residents actually have worked very hard. And one of my residents, in fact, Dr. Neelam, like, she has done a thesis on the, this whole aspect, and one of the main part is the face of the baby. So she was very happy to be, involved in this. So I think we need to, keep learning, and we learn from you. And I think, it's a exchange of knowledge all the time. I think, I'm hoping that, maybe with, more people probably, taking up to 3D ultrasound and all, we'll start getting some more realistic image of the fetal face. Maybe it would kind of, you asked in between, like, would you want something more, before you talk to the patient? So I think that is probably one more thing which, can be added, from the imaging aspect.
So definitely we'll work on that aspect, what Dr. Parvati said, whether we can do a reconstruction of the face and everything. So Before we finish, thank you very much, all the seniors, Bimal Sahni sir, for being here as a mentor, Dr. Khurana and Dr. Praveen in absentia. I'm thanking them because they've been really our motivators to carry on such sessions. Dr. Kaushik, Dr. Parvati, thank you for being the experts here. And Dr. Gayatri, Dr. Neelam, we also remember Dr. Lakshmi Ravi here because that first session was really nice with her inputs in the imaging sign. And Dr. Shagun, of course, for all the hard work that you've done in this session. We thank Conferences International for their constant support in the backend team, Vishal, for always being there for us, and the trade partners who have made this possible. So next month, the third Wednesday, again, we'll come back with something interesting. So with this, I think we close our face. Thank you so much, everybody. Thank you so much.
Thank you. Good
So
night.
see you all at
Bye-bye.
CardioCon before that.
Yeah. You know, we hope to see you all at CardioCon, and if not, at least at FetoCon.
At FetoCon, yes, two important
Very
on-site
important
meetings coming up. So looking forward to catching up with all of you. Bye-bye. Thank you. Good night.